Very good evening, friends. You are watching Surgical Educator RKT. Today we are discussing about very important chapter regarding surgical anatomy of gallbladder, which is anatomy is the backbone of any surgery, and most common cause of injury during lab chole is due to misidentification of the structure, or there is some aberrant abnormal anatomy are very common in case of gallbladder. So we have to know about the surgical anatomy of gallbladder clearly, so that we can perform safe lab cholecystectomy. This is the liver, gallbladder, common hepatic duct, common bile duct, cystic duct, right hepatic duct, left hepatic duct. Gallbladder is a pear-shaped organ located in inferior surface of liver, and there is a two duct, right hepatic duct and left hepatic duct, joined together to form common hepatic duct. After insertion of the cystic duct into common hepatic duct, this is called common bile duct. This is the main structure, most common structure injured during lap cholecystectomy. And common bile duct joined with main pancreatic duct and enter in the ampulla water surrounded by sphincter of Oddi. Gallbladder is a pear-shaped organ, 7.5 to 10 cm long, and it had three parts: fundus, body, neck, and cystic duct. We always discussing about two important things in case of during lap chole, when we are going to dissect the gallbladder from the gallbladder bed. There are three steps for lap cholecystectomy. First is the adhesiolysis, second one is the dissection of the cleft triangle, and third one is the dissection of gallbladder from the gallbladder fossa. Very important thing is the Calot's triangle. Calot's triangle. It is a very crucial part during lap cholecystectomy, dissection of the Calot's triangle. So we have to know the boundaries of the Calot's triangle. Anterosuperior boundary formed by the cystic artery. Medially there is a common hepatic duct. Inferior-laterally there is a cystic duct or lower portion of the gallbladder. Cystic artery is a branch of right hepatic artery. Mostly it runs posterior to the right hepatic duct and enter in the gallbladder. But modified Calot triangles, also known as hepatocystic triangle, in which anterior superior boundary formed by the inferior surface of the liver rather than cystic artery. In hepatocystic triangle, cystic artery is a content, not form a boundary, and content of the Calot's triangle are the cystic lymph node, also known as lymph node of Lund. There is so much variation in arterial system, blood supply, and biliary duct. First we discussing about arterial supply of the gallbladder. Mostly gallbladder is supplied by the cystic artery, which is the branch of right hepatic artery. Sometimes right hepatic artery take a turn, tortuous, and present in Calot's triangle. So we can confuse it is right hepatic artery or cystic artery. Important thing is that cystic artery doesn't show any pulsation before clamping. If we see any pulsatile artery in the region of Calot's triangle, we always suspect there is a right hepatic artery, tortuous, take a turn. It is known as caterpillar turn or Moynihan humps. And after and there is short cystic artery. In case of Moynihan humps, there is short cystic artery. So, and other variation, sometimes artery, mostly artery arise from the right hepatic artery. Sometimes it take origin from the left hepatic artery. Sometimes is a direct branch from the gastroduodenal artery. There is a right hepatic duct, left hepatic duct and cystic duct. Normally, cystic duct insert into common hepatic duct to form common bile duct. Sometimes there is a short cystic duct. So when we are going to clamp cystic duct, always remember that dissection should be done between the gallbladder and the proximal portion of the cystic duct, not the portion which joined the CVD. During lap chole, we never try to see the common bile duct. Dissection between cystic duct and common bile duct should be avoided. This is the cause of CVD injury. Before clamping, there is a critical view of safety. First we discussing about the R4U line. R4U line is a imaginary line. From the R means rubeolar sulcus, 4 means segment 4 of the liver, U means umbilical fissure. All the dissection should be done above the R4U line, okay, to avoid the injury to common bile duct. This is the imaginary line between rubeolar sulcus, 4th segment of liver and umbilical fissure. So dissection should be done above this line. And once we form, first we form the posterior window formed between inferior surface of the liver and cystic artery. And anterior window formed, we create a anterior window between cystic duct and cystic artery. Then we achieve critical view of safety. Critical view of safety given by Strasberg in 1995. The 3 components of the critical view of safety. First, all the fibrofatty tissue or connective tissue should be cleared in the hepatocystic triangle so that we can clearly identify cystic artery and cystic duct. Second one, 2 and only 2 tubular structure entering in the gallbladder. If sometime some tubular structure runs posterior to the gallbladder, it may be right posterior sectoral duct, that causing injury to the duct. And there is cystic artery. Cystic artery should be entered in the gallbladder. Before entering in the gallbladder, cystic artery divided in 2 parts: anterior division of the cystic artery and posterior division of the cystic artery, and a small artery given cystic artery to cystic duct, duct to cystic duct. Artery to cystic duct arise from the cystic artery, very small artery. Sometimes there is a bleeding, so we always consider it may be due to branch of cystic artery to the cystic duct. Sometimes, if due to misidentification, we clamp right hepatic artery in place of cystic artery, what will happen? Nothing will happen immediately, because liver has dual blood supply. Main supply of the blood in the right lobe of the liver through portal vein. So there is no necrosis, no infarction of the liver, but it also provide blood supply to common bile duct. If we clamp right hepatic artery in place of cystic artery, there is a blood supply of common bile duct hampered. That leads to ischemia, followed by necrosis, followed by fibrosis, then stricture. So post-operative stricture can develop after surgery. So we have to clear that critical view of the safety achieved means all the connective tissue and fibropatic tissue cleared from the hepatocystic triangle. Number 2, two or only two tubular structure entering in the gallbladder, and we can see doublet view. Post inferior surface of the liver clearly seen from the anterior window. From anterior side we turn gallbladder to the so that we can posterior view. The only two tubular structure identified entering the gallbladder, it is known as critical view of safety given by Strasberg in 1995. Clamping. First we clamp the artery, but it is not rule. If there is a difficulty, we can clamp cystic duct first and then artery. Clamping, double clamping towards the proximal side and one clamp towards the specimen side. And one thing I am forgotten about the lymph node of wound. Cystic lymph node is a very important landmark for the identification of the cystic artery, because cystic artery lies posterior lateral to the cystic lymph node. If we identify lymph node after careful dissection, we find out there is a cystic artery under this lymph node. And when we dissect between cystic artery and cystic duct, dissection should not be transverse like that. Dissection should be longitudinal so that avulsion of artery avoided. Okay, that's all about surgical anatomy of gallbladder. In next video we will be discussing about the how do we perform safe lap cholecystectomy. Another video, there is a complication of lap cholecystectomy, and then management of biliary duct injury. Thank you.